Very bad. And there we're
Okay.
recording. Thank you.
Hello, everyone. I'm very excited to be here today, talking to you about motor speech disorders. My name is Dr. Yvonne Maldonado de la Rosa. I work currently at a university in Mesa, Arizona, AT Still University. I'm an assistant professor. I am Spanish English bilingual, so Spanish is my native language. So mind if maybe you don't understand something I say. I really try my best, but if there's a vowel that doesn't sound the best, just if you have any questions, feel free to drop them in the chat. If not, like Dr. Higdon was mentioning, there is a whole 1 hour lecture and more in depth going into motor speech disorder. A little bit of my background, I am one of my major emphasis area for, in teaching and in research is about best practices. So what are the current approaches that we do as SLPs to ensure cultural responsiveness, cultural humility, and equity in the approaches we take as assessment or treatment. Pediatric feeding disorders is one of a big one. And the motor speech disorder one is a class that I taught when I was starting here at AT Still, and it's very close to my heart because I ended up loving it more than I thought. So I'm gonna jump into a quick review of the content. If you feel I'm going too fast, you just let me know on the chat, but I did bring a few questions at the end. It may be, maybe I'm just doing a monologue, but I will re-encourage everyone to at least try answering them on the chat. So let's just talk a little bit about a quick overview. So there are two main types of motor speech disorder. So we have dysarthria and we have apraxia of speech. When we talk about dysarthria, we're talking about motor execution disorder. Person knows what to say, but the muscles can't perform accurately because of weakness, spasticity, or some incoordination. And then when we talk about apraxia of speech, we're talking about motor planning or programming disorder. Muscles are fine, but the brain can't sequence those movements correctly. They both affect intelligibility, that efficiency, and that naturalness of the speech. I usually tell students that if you hear something that's predictable, consistent errors, and the key part here is the consistency of errors, think of dysarthria. But if you hear inconsistency and you see groping attempts, which is the moving of the attempts of trying to get out what you're trying to say in the speech component, think of apraxia of speech, okay? And then when we think about speech, it's really not a single process. It has 5 subsystems. So we start with respiration. So that's what we can feel, that's our power source, that breath support that fuels our phonation. Then phonation is our vocal folds vibrating to produce that voice sound. And then we jump into that resonance that controls how much sound travels through maybe the nose versus the mouth, handled by that velopharyngeal port. And then articulation shapes those individual sounds with the tongue, the lips, the jaw. And finally, in prosody, it gives us that rhythm, that speech rhythm, the stress, that melody. And then when we have one of these systems or more than one of these systems break down, our speech will sound different. And listening to which subsystem is off will help us localize the neurological damage, okay? So if we focus on dysarthria first, dysarthria is caused by damage to the central or peripheral nervous system, so CNS or PNS. So it's a neuromuscular control issue. The key features here are consistent and predictable errors, because the muscle weakness or tone problem is stable. So each type of the dysarthria that we're going to talk on the next slide will map a different part of the nervous system. So for example, it could be cerebellar damage, it could be basal ganglia lesion. And as we go through these, we have to listen to those speech characteristics or those perceptual speech factors or patterns. And the key part is the patterns. It's not just like you heard one, it's like those patterns. What is it something that I'm hearing consistent that will help you differentiate between one and the other? Because when we talk about dysarthria, we're not talking about one type of dysarthria, we're talking about quite a few. So these are the types of dysarthria. And you know, where it's 6 types of dysarthria, but there's always that 7th that could be the mixed dysarthria, just to complicate things a little bit more. But when we go about flaccid dysarthria, it really results from lower motor neuron damage. And I like putting the acronyms next to the table because in the praxis, you may have one or the other. So there are some medical acronyms that you should be, you know, open for, and others the praxis will show you or explain to you what would they mean. But it's good to know a little bit about that. So lower motor neuron damage, we're gonna have that breathiness in the speech, that breathy voice. We're gonna have hypernasality. We're gonna have imprecise consonants because of that weakness. Like flaccid dysarthria, we see much more of the weakness component. And then in spastic dysarthria, it's kind of like the opposite. It, you know, instead of just the lower motor neurons, we're talking about now the bilateral upper motor neurons. So the speech sounds are going to sound strained, slow, that strain, that strangle, that spasticity with a tight, effortful quality. So if you envision like the possibility of how that client will feel within the muscles, it's how the speech will also be affected. When we go for ataxic dysarthria, it comes from cerebellar damage. So we're going to have that irregular articulation. So we're going to have like uncoordinated speech sounds. We're going to have irregular articulation. We're going to have excess or equal stress. So a lot of the times, and that's why I put it in parentheses, you know, in apostrophes, people call it like that type of drunken quality of speech. And hypokinetic is the one that we often seen when we're talking about Parkinson's disease. It is in the basal ganglia, but specifically in the substantia nigra, and it features that reduced loudness, those short rushes of speech, and that monotone speech. And you have to also consider that, you know, the facial component of hypokinetic dysarthria, because when we talk about hyperkinetic dysarthria, it's also in the basal ganglia, but it's in the caudate or putamen area. So in this one, we have the opposite. We have excessive, we have involuntary movements from that basal ganglia change. You'll hear those sudden pitch or loudness shift. That's variable rate. And a way that I like showing it to students in the classroom is in those two in particular, I showed the gait of the hyperkinetic dysarthria and hypokinetic, because if you see how they're walking, and in hyperkinetic we're going to have that dyskinesias and the chorea, and chorea, think about choreography because that's where it comes from. So those, you know, involuntary movements that can't be controlled, then that's how the speech is going to be, which is sudden, you know, shift of loudness, variable rate. And in the UUMN, which is the unilateral upper motor neuron, we're going to have, it's quite mild. So we're going to have, you know, mild imprecise consonants. And some people, you know, not some people, it is said that it's quite transient because of the mildness. And then the mixed dysarthria occurs when multiple systems are affected. So let's say like ALS. And you know, if you have more than multiple sites affected, when you talk about those key features in speech, it's going to be a combination of those speech features. So common mixed dysarthrias could be spastic and flaccid and so on. I like to remind students in this case that each dysarthria type will give you a neurological map of where that lesion is, okay? And it helps you if you see a question that has a lesion map, you will know what type of it is, but you can't always consider just knowing the lesion type. You have to know those key features. And this is just a summary of the table, but in the recorded session, I go one by one with more specifics. And then when we move to apraxia of speech, or AOS, I didn't write it there, unlike dysarthria, apraxia is a disorder of motor planning and programming. So there's no weakness or paralysis of the speech muscles. The problem will lie in that coordination of the, coordinating the sequence of movements to produce those sounds. So you'll hear those inconsistent errors. The same word might be produced differently or correct one time and then completely different the next time. Another hallmark is what I mentioned before, which is the groping or that visible struggle as the person tries to find that right articulatory position. Prosody, we often see it disrupted, but the speech sounds are slow, segmented, and effortful. And that automatic speech, like greetings, counting, days of the week, or some songs that they're completely used to, tend to be easier than purposeful of those novel or things that are new to them related to speech. Apraxia often can co-occur with or can occur after a left hemisphere lesion, particularly close to or around Broca's area or in the insula, and can coexist with Broca's area. The key here is that inconsistency and effort. The Dysarthria is consistent and you see weakness, and in apraxia you have inconsistent planning. And if you see here, I talked about more articulation and maybe some prosody on the side, but despite different from dysarthria, in dysarthria we may have more than one of the speech 5 subsystems affected. So we're going to always consider those 5, unlike apraxia that we don't, not all of the 5 are affected. So the main one is that articulation and prosody. But we also have in the pediatric component, the childhood apraxia of speech, or CAS. Is that developmental counterpart of what would be AOS. It's not acquired from stroke or injury, but rather that developmental breakdown of that brain's ability to plan and program the speech movements. So according to ASHA in 2007, through a consensus, there are 3 core features: inconsistent errors on consonant and vowels, the lengthening or disrupted transitions between sounds and syllables, and that abnormal prosody, particularly incorrect stress patterns. And you might also see like some other things. You can see that groping, vowel distortions, voicing errors, and sometimes that schwa insertion between the syllables. So children with CAS may appear to have limited phonemic inventory, but struggle more with complex and longer words and show that visible frustration, hence sometimes the groping. That is the big distinction from hearing phonological disorders is that this is a motor component, not a linguistic component. So when we go into the therapy, think of therapy being intensive, frequent, focus on that building of the accurate and consistent movement of patterns. So not just the sound accuracy. And with my scope of practice and what I love, it's that I want to pause into the importance of the ICF framework, International Classification of Functioning, Disability, and Health. If you haven't heard of it, ASHA has a great resource page that gives you not only the definition, but many PDFs that will talk about how to see ICF in different disorders. So in ICF, it just helps us look beyond the impairment and consider the person as a whole. So when we're considering motor speech disorder and we talk about body structure and functioning level, we're looking at that physiological impairment like weakness, tone changes, or reduced coordination. On the activity level, we focus on how well they perform on the task, intelligibility, rate, clarity. On the participation level, we consider that how does that impact their real life? Can the person communicate at work? Can the person communicate with their family, school, etc.? And those contextual factors are divided between environmental and personal. So in the environmental factors, we have to consider the background noise, which could be like when they're talking, is there that background noise behind them? How are their communication partners reacting and talking to them or communicating with them? And the access that they may have if needed to alternative and augmentative communication. Doesn't have to be high level, it could be low level to help them during the speech as they improve or depending on the severity. And lastly, the personal factors. Motivation. Someone will not work well in therapy with you if they're not motivated. We need to know about their motivation. We need to know about their personal state, their emotional state, I mean, and those cultural considerations that could, all of this, when we put it together, impact evaluation process and the treatment component. So as we're developing goals while we're doing the comprehensive eval, we have to tie them to this model in order to get the goals functional and person-centered. And the reason I put it before the talking about the evaluation is because you have to keep all of these things in mind when you're doing an eval, because remember, from the eval, you create your plan of care. So you're needing to get all this information to attain a baseline of your client in ways to understand how to support them. And in a comprehensive motor speech examination, disorder examination, and I like mentioning comprehensive, and in comprehensive, it should be very similar in all of the areas. So we should have a case history, we should have an interview, but we should also have an ethnographic interview. There's very different components. Oral MEC, an informal task or criterion reference task. We talk about standardized assessments and so on. So in the specifics of motor speech disorder, our goal is to determine the presence, the type, and the severity of the disorder. So we need to identify which subsystems are involved. So the process begins with that case history. We need to understand the onset, the progression, and the impact. Then oral mechanism, strength, tone, range, symmetry, coordination. The speech task, sustained phonation, pataka, AMRs, SMRs, repetition, connected speech. Why? Because there we can do that perceptual analysis of which subsystem may be impact, plus the salient features of strength, speech, range of motion, accuracy, steadiness. If we have the chance, we will do standardized assessment, and there's a few on the book and on my whole hour talk. And we can use intelligibility measures to understand their speech rate at a different word and sentence level. And these results interpreting can give us that ICF component. And then if we talk about the treatment principles, we should always consider those two major frameworks. So treatment should balance that restoration, compensation, or participation. And we cannot forget neuroplasticity, use it or lose it, use it and improve it, repetition and intensity matter, specificity, salience, and age and time. All of this will help us understand those principles that can help us not only activate the skills, but understand how by practicing the skills, we can get more stronger and efficient as we go forward. And the motor learning consideration, it is a motor speech disorder. It talks about the feedback. It talks about the scheduled practices. So if we do mass practice, we can get better acquisition, but we can not get necessarily generalization versus distributed practice, blocked versus random. How are we offering the feedback? Because it will change the outcomes or the quality of how the patients are producing their speech and so on. And then before we go into the question, the treatment component. So we've talked about all these 5 components or subsystems, so treatment can be separated by subsystems. So if I know respiration and phonation are impacted, what are the best ways to go? I can go with behavioral techniques, I can go with postural adjustments, I can go with prosthetics, I can go in phonation for getting more efficient and balanced vocal fold closure, so I can get in hypoadduction, I can use LSBT loud or push and pulling exercises. If there's hyperadduction, which means too much tension, I can work on relaxation and easy onset. If we work on resonance, that's really much the bilopharyngeal system. So we're going to be working a lot on behavioral management, but there are other approaches that go beyond us doing a referral. So prosthetic management and surgical management. In the articulatory component, we have to show or work on precision and coordination over articulation strategies, phonetic placement, contrastive drills, slow rate, pacing boards. And then in the prosody, we want to target that rate, rhythm, and those stress patterns. So it could be rhythmic pacing. We can use a metronome. We can do chunking phrases that can improve that naturalness of speech. And when we talk about apraxia or CAS, here we really do apply the motor learning principles directly. So we can use structured, hierarchical approaches like dynamic temporal, tactile cueing, prompt, SPT. We want to really focus on intensive, repetitive practices with fading cues, okay? And then I'm jumping in the practice of the questions. What I try working with students and what I hope that you try doing for your praxis is that if you only have 150 minutes for 132 questions, practice enough questions where you time yourself in doing them or achieving them in at least 60 seconds or maybe less, because there may be some questions that you are longer and you need more than a minute, but you shouldn't take more than a minute in each question so you have time to go back and see some other questions. So the plan here is I'm going to show you a slide with a question and 4 options. So it's a multiple choice question. Ideally, I will give you 30 seconds, let's say, per question, and then you don't have to unmute yourself. It would be beautiful and you unmute yourself, but I'm not forcing anyone. You can also send the answer in the chat. I encourage you strongly to try answering. I don't mind if it's a correct response or an incorrect response. Just put it out there, feel comfortable, because I will still show the correct answer afterwards, talk about the why of that answer, and describe why not the other ones, okay? So if we're moving into it, let's go to the first question. Which type of dysarthria is associated with hypernasality, imprecise consonants, breathy vocal quality, and damage to the lower motor neurons? Perfect. So I'm not going to stay a lot on that because I did get kudos to you. Thank you so much for putting it on the chat. I do see some question answers in the chat, and indeed it is flaccid dysarthria. So in this one, it is talking about some, speech characteristics. So we do see hypernasality, breathy voice quality, and imprecise consonants. Those are key speech perceptual features on flaccid dysarthria. Okay, but if you don't remember those key perceptual features, you can go into where the lesion is. So lower motor neuron is a result of does result in flaccid dysarthria. Why not spastic? We're talking about more phonation and articulation. Strained, strangled, not breathy. Muscle tone is high, not weak. In ataxic dysarthria, we're gonna have it would sound more uncoordinated, irregular breakdowns, excess and equal stress, so not hypernasal or breathiness. And in hypokinetic, it really is when you're describing that Parkinson's type, so fast, quiet, monotone, short rushes of speed, not breathy, and then it does have another lesion location. What is an appropriate treatment option for a person with dysarthria who presents with an hypoadduction disorder? Okay, so I have a few on all of the time. So their response is B, loudness training. So when we see the term on this one, hypoadduction, we know that it means that the vocal folds are not coming together fully during phonation. So this results in more breathy, weak, and low intensity type of voice because air is escaping through the glottis. So the most appropriate treatment for here in this case is that loudness training. So here we see a little bit of the Lee Silberman voice treatment. We may see the speak out approach, which focuses on increasing that vocal effort, respiratory drive to improve that closure, that glottal closure. Why not A, in tension reduction? So tension reduction would be, instead of hypoadduction, it would be more for hyperadduction. So in hyperadduction, it's an excessive closure or strain, so spastic dysarthria. So reducing tension would worsen hypoadduction disorder because now we want to kind of like close it. So loudness training will help us close that. In integral stimulation, that really goes into articulation and motor planning. So not necessarily, it's more for apraxia of speech than dysarthria. And abnormal trussing, it's a technique that offers an external support to the abdomen, and it's sometimes used for clients with respiratory weakness. So not necessarily talking about a hypoadduction disorder at the vocal fold level like this one. Again, thank you so much. What is an appropriate perceptual feature of dysarthria indicating the presence of a resonance disorder? Good. And if we keep moving like this, we may go to the longer one. So yes, hypernasality. So in this case, monopitch would be prosodic. Audible inspiration would be more respiratory phonation. Breathiness is phonatory, or we're talking about that breathiness component. Hypernasality is the one that has to do with resonance disorder, bilopharyngeal mechanism. What is a characteristic that can be used to distinguish AOS from dysarthria? See some answers, so I'm going to go to the next one. And it's correct, it's B. Persons with dysarthria typically present with consistent speech sound errors, whereas persons with apraxia present inconsistency. Remember that when distinguishing AOS from dysarthria, the key difference lies in that motor planning versus motor execution. And in dysarthria, we're looking at that consistency versus in apraxia, we have that inconsistency. Option A, which is co-occurring with dysphagia or swallowing disorder. Dysphagia is more common in dysarthria. Novel versus rehearsed task. People with AOS usually perform better with automatic task. Remember that. And when we talk about the deficits across subsystems, the opposite is true. So dysarthria will affect or can affect all subsystems versus AOS will primarily affect articulation and prosody. Which type of dysarthria is associated with irregular articulatory breakdowns, excess and equal stress, harsh vocal quality, and damage to the cerebellum? Correct? For those who have answered it again, we are talking about ataxic dysarthria. In ataxic dysarthria, we do have irregular articulatory breakdowns, excess and equal strength, harsh vocal quality. Think about that in coordination, but the giveaway here was also the cerebellum. We're talking about that in coordination. The hallmark feature of ataxic dysarthria is that scanning or drunken type of speech. So hyperkinetic is involuntary, unpredictable, basal ganglia damage. Unilateral upper motor neuron dysarthria, it's also what the name says, which would be a lesion in the unilateral upper motor neuron area. And in hypokinetic dysarthria, it's also basal ganglia lesion. What is true of childhood apraxia of speech? Love it. You guys are quick. Correct. C, it is often associated with length and disrupted co-articulatory transitions between sounds and syllables. If we consider even that consensus from ASHA in 2007, we're talking about inconsistent errors, lengthening and disrupting transitions, inappropriate prosody, lesion in the frontal lobe. Unlike apraxia, CAS doesn't have an identifiable neurological lesion. It is often of unknown etiology, possibly genetic or neurodevelopmental basis. Co-occurs with dysarthria. CAS and dysarthria are different motor speech disorder. CAS involves planning, programming, while dysarthria is more execution and weakness. They can coexist, but it is not typical or defining in this one. Does not impact literacy. This is false. CAS frequently does affect phonological awareness, spelling, reading development, because consistent speech sound errors and limited sound inventories interfere with those literacy foundations. Good job. What is intelligibility? Okay, so I see B, the main one here. So what is intelligibility? The correct one is D. When we talk about intelligibility, we're referring to how well a listener can understand what a speaker is saying, specifically based on accuracy and clarity of their speech sound production. It's a perceptual measure, meaning that it's judged by how easily speech can be understood by an unfamiliar listener. So intelligibility can be affected by articulatory precision, resonance, voice, prosody, but its definition focuses on perceptual adequacy of speech sound production, making option D the best answer. Why not A? Prosody contributes to the naturalness and rhythm, but intelligibility is not defined by prosody alone. Some can have a normal prosody but still be intelligible. Why not B? That I see it's one of the main answers here, which is the extent of understanding of a speaker. This is close, so you're not completely incorrect. If we were to choose which one are the two best answers, it would have been between B and D. It's close, but it's still too broad. So understanding may also depend on the context, the listener familiarity, and or linguistic cues. So not just the speech signal itself. Intelligibility specifically refers to the clarity of that acoustic signal that's being produced in that perceptual component. And C, it refers to speech rate, so not intelligibility. Although rate can affect intelligibility, too fast or too slow can reduce clarity. It's a separate concept. So in this case, the best one, and it's number D. It's that perceptual adequacy. If we go around this room talking, you can all rate me at different levels of intelligibility. So it's about that speech sound production. How is it? So the extent of understanding, it's just too broad that it doesn't capture what intelligibility by meaning could be, okay? According to the principles of motor learning, which practice schedule type leads to best generalization? And I went fast towards that one, but it is in the whole 1 hour lecture that's already available for you. So we're a little all over on this one, and that's completely okay. When applying the principles of motor learning to our speech therapy, the goal is not only acquisition, it's, getting the skills right, but we want generalization. So being able to use that skill across settings, context, and time. So research has shown that distributive or low frequency practice where sessions are spaced out over time, it promotes better retention and generalization than mass practice. So mass versus distributed, here it just described it instead of putting distributed practice. So which involves many repetitions in short time. Spacing practice gives the motor system time to consolidate that learning, much like how space studying, like if you space your studying time for courses, will help your long-term memory later on. So that's why low frequency practice schedule, because remember it's scheduling, so I'm distributing that practice through the schedule. Doesn't mean I'm not doing a lot of practice leads to better carryover outside of therapy. So one is more about acquisition versus generalization, and this one is more generalization. So when we do mass practice schedule, this type of practice where we have many trials in short time, it improves the immediate performance, but skills don't often generalize well or sometimes are forgotten quickly. Excessive practice schedule, there's no defined excessive schedule in motor learning principles. What matters is that distribution and variability, not sheer quantity. And for D, delayed is not also a recognized type of practice schedule. It might imply waiting too long between sessions, which can actually hinder that possible acquisition. So in this one, it would have been between A and C, being A more a best one for acquisition and C for being better for generalization. Which type of dysarthria is associated with distorted vowels, monoloudness, voice tremor, and damage to the bilateral cerebral hemispheres? Okay, a key one here is the word bilateral, okay? So when you see, and it's written different, it says bilateral cerebral hemispheres, but when you see bilateral upper motor neuron involvement, think of spastic dysarthria. So in flaccid, we had lower motor neurons, and in spastic, it was the one that said bilateral upper motor neurons. So it's saying that the lesion is bilateral. Think of always spastic dysarthria. It results from damage to both the direct and indirect pathways of the upper motor neurons, often due to stroke, cerebral palsy, TBI, that affects both hemispheres. Hallmark feature here is, and it was a tricky one because it didn't mention that strained strangle voice quality, but it did talk about the monoloudness, the slow rate, the distorted vowels, which would fall under imprecise articulation. That's one. Sometimes it may come with mild voice tremor due to that increased muscle tone and reduced flexibility. Why not A? A is cerebellar damage causing irregular articulatory breakdowns, excess and equal stress or incoordination, not, tight quality seen there. Hyperkinetic, basal ganglia dysfunction, involuntary movements, sudden voice stoppages, variable rate, not that consistent spastic pattern or bilateral lesion profile. And in hypokinetic, it's also associated with basal ganglia control circuit damage related to what we know as Parkinson's disease, reduced loudness, short rushes of speech, and rapid rate, not distorted vowels or strain quality. So in this one, the catchy one was that they changed the how to describe the lesion, but by saying bilateral cerebral hemispheres is still talking about that bilateral upper motor neuron environment because involvement, because it still goes into both hemispheres, direct and indirect pathways. But I still do appreciate that you're answering the questions. What best describes the motor learning principle of type of feedback? And again, I not only like that you're interacting, it's more of when you answer the question, it tells you how comfortable you are with the topic or not. So it gives you an idea of what to focus more later. In this case, when we're talking about motor learning principle and the type of feedback, it really goes back to the definition, similar to mass versus distributed. So here, the correct answer is the answer D, knowledge of performance. So when we talk about the type of feedback in motor learning, we have two types, which is KR and KP. That's why you see it over and over. KR, knowledge of results, feedback is about the outcome. So whether the goal was achieved. KP is about the movement of the pattern or the quality. So how was the task performed? So in the early stages of speech motor task, when we talk about KP, it is especially helpful because it gives that learner the information of how to modify the movement patterns. So for example, tongue placement, lip rounding, this type of feedback supports directly acquisition, getting the movement right during practice, versus the KR, when it mentions number A, which is regarding the quality of motor behavior, it's incorrect because KR is more about the outcome, not the movement quality. B, it talks about KB is feedback regarding the success in achieving motor behavior. It is describing KR, not KP, so it's mixing definitions for you. And in C, it talks about KR leading to improved acquisition, and KR is more for retention and generalization. So same as mass versus distribution, one was about acquisition and the other one was about generalization. So KR would be more leading more for generalization versus KP will lead more to acquisition, making option D the best one. Which is a typical treatment method used to improve the respiratory and phonatory subsystems? Perfect, correct. Yes, it is number 8. LSBT is an evidence-based, or Lee Silverman Boyce treatment. LSBT is an evidence-based intensive therapy program that it's originally designed for individuals with Parkinson's disease, but it also has been used for other hypokinetic or phonatory respiratory disorders. So it targets both the respiratory subsystem and the phonatory subsystem. So this is where you talk about think loud or talk loud, encouraging patients to increase that vocal effort so it improves loudness, clarity, and overall speech intelligibility. When we talk about integral stimulation, it's more the integral stimulation, it's the watch me, listen to me, and say it with me approach. So it's more for AOS, focuses on motor planning and sequencing. EMST, expiratory muscle strength training, targets respiratory strength. It's not a comprehensive approach for phonation or voice quality. It's more usually used to support the cough, swallowing, breath support, but not loudness directly. So more respiratory, not phonatory. And contrastive stress, it's used to improve prosody and intonation. So could be used in dysarthria, but could be used in AOS, but it's not directly used to strengthen the respiratory and phonatory subsystem. So the best one is A. Which clinical characteristics most closely represent the diagnosis of CAS? Correct. It is D. Hallmark feature that best distinguishes CAS from other speech sound disorders is that inconsistency in speech production. So why not the other ones? A, it's that that's more characteristics of dysarthria or phonological disorders, not CAS, that will affect both consonants and vowels due to that disrupted planning. Why not B? Vowel distortions do occur in CAS, but the key diagnostic feature is the inconsistency across those attempts, not just the presence of the distortions. And not C, because these features may appear in CAS, but they are secondary characteristics. Inconsistency in speech sound errors remains the most defining and diagnostic type of hallmark. So that is why it's one of the best options. And it says most closely represent. So that's where the praxis may catch you. So you have to be very mindful of which one is the best, which one is not, most closely. And those are the key parts into tying it closer to the real diagnosis or definition. Which of the following types of treatment for apraxia of speech involves improving spatial and temporal aspects of articulatory movement? Correct, it is the A. When we treat AOS, our goal is to help the person plan and program articulatory movements more accurately. So articulatory kinematic approach directly targets that spatial, so place, manner, and temporal, so timing and sequencing aspects of the movement. High frequency of practice, while it's a frequent practice of the motor learning principle, it talks about more in this option of practice intensity, not a specific treatment type. Rate and rhythm, it's more prosody and temporal based approaches, and AAC more compensatory communication method. What is apraxia of speech? Beautiful. I see the answers and I'm going quick on this one, but yes, correct. It is B. It is a motor speech disorder characterized by motor planning deficits. If it were motor execution, we would be talking about dysarthria, which can help diagnose or distinguish between childhood dysarthria and childhood apraxia of speech. Does have longer options, so I'm letting you. So what can help us distinguish between childhood dysarthria and childhood apraxia of speech is option B. To distinguish between CAS and CD, we have to think about where the breakdown occur. So the option where it says that in CAS, we typically have only articulation and prosody, whereas in CD, we have all the speech subsystems as the correct one. It really goes with the same as AOS and dysarthria. When we talk about groping behaviors, it's groping is more of CAS, not dysarthria. That's why it's not A. C, we're talking about it's reverse. So dysarthria often co-occurs with neuromuscular conditions, whereas not CAS. And in D, it's not D because CAS is characterized by inconsistent errors, not just distortions. And, childhood dysarthria tend to have more consistent, predictable errors based on weakness or tone, not variability. As treatment of CAS, which speech subsystem is targeted through dynamic temporal and tactile cueing? Perfect. Correct. Articulation. And we know that in CAS or apraxia of speech, we mainly have the subsystem affected as articulation and prosody, but not necessarily respiration and phonation. So at that point, when we talk about DTTC, it's working for an articulatory kinematic approach, so definitely articulation, which is typically treatment method used to improve the respiratory subsystem. Correct. And I'm going a little quicker on these because I want to see if we can do at least one long one. But yes, it is expiratory muscle strength training, evidence-based to help with the evidence-based treatment to help with the respiratory subsystem. Effortful closure would work more on phonatory subsystem, phonetic placement, articulatory subsystem, and relaxation techniques or strategies would go more into reducing that hyperfunction. So it could fall into both the phonatory subsystem. Which type of dysarthria is associated with imprecise consonants, decreased loudness, harsh vocal quality, and one cerebral hemisphere? Correct. You got it. It is C. So we're talking about unilateral. So it is the unilateral one cerebral hemisphere talks about unilateral upper motor neuron. The key clue here is one cerebral hemisphere. It's just damage to the upper motor neurons on one side of the brain. Remember, hypokinetic is basal ganglia, spastic is bilateral upper motor neuron damage, and flaccid is lower motor neuron damage. What is considered a type of prosodic impairment in motor speech disorder? Yes, good. Excess and equal stress, it's prosody. Palilalia, it's a speech repetition phenomenon. Diplophonia, it's perception of two simultaneous pitch. So it's voice phonatory, and audible inspiration is more respiratory and phonatory. So the correct one is A. Good job. So we are getting to a longer one. And here it is. I'm gonna read it. You can ignore me or not. But a patient incurred in a left hemorrhagic infarct with resulting apraxia of speech. Verbal communication consists of a few automated words and phrases. When speech sound errors occur, they are distorted. Reading and receptive language skills are intact. Adaptive techniques used to suggest writing skills appear to be intact. Which treatment approach is the best, and I put it in caps lock so you don't forget, for improving verbal expression? Correct, it is C. Because this patient demonstrate relatively intact receptive language skills and has moderate to severe AOS. They are perfect candidate for an articulatory kinematic approach. Use of this approach focuses on improving spatial and temporal aspects of the articulatory movements as means to improve that speech production. This will help improve the patient's distortion of phonemes, thus helping with that improved verbal expression. An SLP in a skilled nursing facility is working with a patient diagnosed with dysarthria. The SLP notices that the patient fails to take a breath to replenish the air supply, which leads to the patient talking into reserve volume. The patient exhibits loudness decay when this occurs, and breath group length are longer than age and gender match controls. Which treatment approach is the best for this patient? So in this case, the correct answer is C. the type of breathing pattern that this particular patient or speaker is exhibiting is not efficient from a communicative perspective. So focusing on reducing the maladaptive respiratory behaviors can lead to that reduction in loudness decay, age and gender appropriate breath supports or groups. The speaker should be instructed to use or in optimal breath groups and to replenish that air supply at moments that are appropriate within that conversation. Remember that in this case, it's not talking, it wouldn't be LSBT because it's not talking necessarily about, it is lowering on loudness, but it's like their breath group length are longer than what it would be matched in, that regular control. And that's what it's reducing that loudness. So taking away that maladaptive behavior could be the best. And Dr. Hickton, you correct me if I'm wrong, but I think it is 8. So is that the time?
It is 8 o'clock. You can go on for, we usually say 8:15. So if you have more questions, you can keep going.
Okay. I do have more questions if it's okay with you guys. So I can start. If I see that you guys are leaving, then I can leave. But here we have another one. These are the longer ones. An SLP has recently changed job settings to work in a clinic specializing in the treatment of motor speech disorder. A new patient arrives for a comprehensive motor speech evaluation, during which the SLP records a speech sample for later review. Upon review of that speech sample, the SLP is questioning whether the patient demonstrates dysarthria or AOS, which would be the best characteristic to differentiate these two motor speech disorder. That is correct, Savannah. While there are many differences present between dysarthria and apraxia, that can help with differential diagnosis of these two conditions, the best characteristic in this scenario is that the speakers with dysarthria often demonstrate respiratory subsystem deficits that are not seen in apraxia. In dysarthria, we can see often some level of damage in all 5 speech subsystems, so articulation, phonation, respiration, prosody, and resonance. While speakers in AOS often only demonstrate deficits in articulation and prosody. So when we consider the more neuromuscular conditions is more associated with dysarthria. Dysphagia, it's more with dysarthria, and inconsistent speech errors is more apraxia than consistent. So that's why C is the best answer. And then I think I have one more. Let's see. SLP working in an acute care hospital completes a comprehensive speech and language evaluation on a patient present with a left frontal lobe CVA. During the evaluation, the patient presents with a slow rate of speech production with lengthening intersex durations and articulatory groping behaviors, which condition best coincides with the patient's symptoms. And in this case, the correct answer is correct that it's D. So remember that apraxia of speech, motor speech disorder, often seen occurring with frontal or parietal lobe damage, but one of the hallmark characteristics of this disorder is that lengthening of speech, slow rate, articulatory errors, and main part of this one that I would take away is that groping behavior. So the groping behavior, we see it more in apraxia of speech. We may see some in ataxia, but it's a hallmark of apraxia of speech. Let's see. Ooh, I have. And I think I read too slow for you guys because you were answering while I was still reading. So I'm going to give you guys a few seconds. So here, look for the best course of therapy in order to maximize the speaker's incomprehensibility. And that is correct. It is A, because the patient has a significant disorder and minimal ability to compensate on their own. AAC modalities should be explored in an effort to increase that patient's ability to communicate effectively within conversational partners. And this is the last one. Ah, so which one is the best? Which option best exemplifies how pacing boards can reduce naturalness and naturalness of speech? So in this one, the correct answer is D. So when we talk about a pacing board is a method to use when patients exhibit deficits that would benefit from slowed, altered rate rhythm of speech. So a pacing board usually contains specific areas that could differentiate by some type of visual. So it could be like a tape, a wooden slot, which during which a patient is allowed to speak in a predetermined number of words. So you're forcing the patient to speak with some specifics, so it changes that naturalness. So because pacing boards are used in a way to limit the amount of speech output, so it could be one word per space on the board, this can lead to longer pauses in between words and pauses in linguistically inappropriate areas. So that is why the best one would be the D. And then that is the end of my questions and the whole presentation. If you have any other questions, I can stay on for maybe 2 more minutes. I hope it was useful. I do encourage you to continue coming to the office hours and, hearing all of us talk about all the different topics. And the best way to practice is exposing yourself to answering questions, even if you feel you're not doing the best. It just shows you where you need to improve or where you can study more. So thank you so much for being here tonight, and I wish you guys the best. I'll wait for Dr. Hickton to tell.
Thanks to everybody. Thank you so much. That was a great presentation. I really appreciated it. And remember, folks, that we will see you the next time, December 3rd, those of you who come back for that. And have a good Thanksgiving holiday and trip to Asha if you go to Asha. Thank you, Bone. Appreciate
Bye.
it.
Have a good day. Night.
Bye-bye.
Bye-bye.